Welcome to the DaVinci Hour podcast, presented by DaVinci Academy. I am your host, Dr. Maxwell Cooper. This episode is a part of our DaVinci Innovators series, which feature physicians, inventors, and entrepreneurs working on innovative medical technology. Our guests for these episodes discuss developing new medical technology, building medtech companies, and advice for anyone going through the process of medical innovation. Hey everybody, welcome back to the DaVinci Hour podcast. This week I'm joined by the co-founders of Ferrum Health out in San Francisco, California. I'm joined by the CEO, Pelu Tran, and then the CTO, Kenneth. So welcome guys, appreciate you coming on. Why don't each of you guys tell me your kind of a little bit about your background and then how you both came together to start this company?
Sure. So my background, I actually came out west from the East Coast for an engineering undergraduate and medical school at Stanford. Was applying into radiology when I actually started my first company. So a typical Stanford med student, go on leave, start a company, get venture funding, and ultimately ended up bringing the company public via SPAC a couple years back. And from there had an opportunity to work really closely with a lot of the nation's leading health systems, strategics like McKesson, DaVita, and we realized some just fundamental challenges with how hospitals were adopting technology and some real patient needs that were out there that we had an opportunity to address. So that's how we started Ferrum.
Yeah, and on my end, I started programming back in the 5th grade when BASIC was still a thing, and eventually got a BS and MS in computer engineering with a focus on security and information assurance. Then went on to these enterprise companies from the get-go, things like Harmonic or Cisco, where we're building out these like high-performance softwares that ship on hardware that installs in someone else's data center. And so when I was speaking with Pelu and, spoke a lot of times because we met back in 2010, 2011, and just speaking with him about the challenges about healthcare, that one notion of shipping software on hardware that gets deployed somewhere else was a far cry from what the industry was moving to, which is cloud. And it seems like that kind of skill set really fit in healthcare's alley. And that's how we ended up with Ferrum.
Awesome. No, thanks for that background, guys. Appreciate it. So I guess why don't we start with what exactly is Ferrum Health? What's your guys' mission? Like what type of products and services are you guys offering, and like who your typical clients are?
Yeah, so we founded Ferrum coming out of my previous company, really because I guess I had a personal experience that really ended up shaping how I thought about technology. We're sitting here in the hotbed of innovation and startups and AI and transformation and disruption. And I had a family member, my uncle, who actually ended up passing away from late stage lung cancer. And the challenge with that was that his cancer had been present on imaging studies several times before. It had actually been missed by his doctors 3 different occasions on 3 different imaging studies. And by the time it was diagnosed, of course, he ended up having widely metastatic disease and dying a few months later. And this was in an environment where I knew for a fact that there were 8 different companies with FDA cleared solutions that would have cost $1 to have been deployed on this imaging data and to have helped find his cancer. But as we all know, right, adoption of AI continues to lag behind. And so the average doctor who's making a diagnosis is usually making it without the help of AI. And that's what happened in his case. And it's what drove our mission of trying to make healthcare intelligent. So I guess Ferrum does that by trying to give hospitals' IT systems the platform that they need to be able to efficiently deploy AI algorithms locally within their data center environment. And we can talk a little bit about why that's so important and the benefits of that. But at a super high level, we provide hospitals with an AI platform that they're able to use to deploy and manage their AI solutions securely and safely.
Gotcha. No, I'm sorry to hear that about your uncle. And, that's definitely gives you a little more inspiration for sure for tackling this type of challenge. And I'm curious where the scans that he had, you said there were no AI. I think I've heard you on another interview that you ended up applying some of your algorithms to his scans and seeing that things unfortunately would have been caught had they been used.
Yeah, exactly. On both X-ray and CT scan. So low to CT screening, X-ray. I mean, I think Many listeners are probably familiar with the invisible gorilla study that came out of Harvard a few years back, where they literally put a gorilla in the middle of a lung CT scan, and like over half of the radiologists missed it. So something that happens surprisingly frequently, and in my family's case, unfortunately, happened to a family member.
Yeah, no, thank you for that overview. Appreciate it. So I guess at a high level, you guys, I was looking on your website, you offer these AI hubs. So is essentially, do you guys develop your own algorithms in-house, or is it more, you offer other algorithms as well?
Yeah, so we're not in the AI development house. So let me take a step back and just kind of explain how Ferrum works. Our mission is really to help hospitals work with these different AI companies, right? The current approach to deploying AI solutions, if you're a health system, IT organization, is profoundly broken. These IT teams are some of the most under-resourced, understaffed, underskilled in any industry. And they're somehow being asked to bridge this 30, 40-year divide in technology, where you have legacy OEM systems, right? Like the GE, Philips, Siemens, Canon, Fujifilms of the world. And they're being asked to bridge these legacy systems with these modern cloud-based API-driven AI solutions. And if I'm in a hospital IT team, like all of that burden falls to me, right? Pulling the data sets, sending it out to the cloud, having these companies compute on it, receiving the results back. And so I have no visibility into the security or use of patient data. I have no ability to actually understand the performance of these tools, and I have no ability to scale, right? Every solution I integrate with it doesn't prepare me at all, or doesn't give me anything I need to integrate with the next vendor. So we realized that there have been some advancements made in Kubernetes and remote management, and just the kind of how standard AI tooling has become, that allowed us to, instead of sending patient data to the cloud, allow hospitals to download these applications via containers into a locally hosted environment. So really running these applications locally, rather than having to figure out how you're going to integrate with a bunch of different vendor clouds. And that allows hospitals to deploy applications with a click of a button. It allows them to have complete visibility into how these tools perform, and it allows them to have the confidence that patient data isn't going to end up in the hands of someone who it shouldn't end up with.
No, that's amazing. So it's you're essentially, it sounds like you're helping hospitals and hospital systems further or more easily adopt these AI algorithms into their system, which, because I imagine is a pretty big technical challenge. And as you said, like that a lot of IT in these hospital systems is incredibly complex and may even be outdated, as I'm sure in some instances. So, but Ken, I'm curious from your end, like at the CTO level, like what aspects like is kind of your focus, and what are you like from day to day, I guess, what's your team working on in this aspect as well?
Team is really working on trying to support all of this, and also the AI hubs in general. So because the AI hubs have a lot of shared similarities, but they also have their own unique differences between them. If you break down the AI hubs that we have, it really gets categorized into 3 different workflows. One would be something like a worklist triage update. One is a point of care, something more real time, where the physician is able to sit down, see the scan processed and analyzed by the AI algorithm before they sit down. And then also on a second read, or something that would have been more for quality. And so at a high level, all of these workflows, they have the same goal of working in the background, processing data fast enough to be there for the radiologist before the radiologist is there, and then also being simple to implement across the enterprise. And that's why we treat on-prem as a first-class option. And so on the technical side, we're really focused on trying to make all of that happen and all of that scale, because we have more increasing amounts of data being processed, increasing amounts of AI algorithms to be processed, and making sure that it all works in a timely manner is a pretty big endeavor.
Yeah, no, I can imagine. And I think from what it sounds like, there's no hardware involved with this at all. It's all, like you said, moved to the cloud for like, as far as like the host of your applications and that type of thing.
So we actually bring the cloud to the healthcare systems.
Okay.
And so we do that by treating on-prem as a first-class option, not just cloud, even though we support both. 10 out of 10 times, because it's healthcare, they're going to start off with on-prem first. And because of that, we really work to ensure that the environment that our partner ML algorithm developers deploy in is something that we can emulate on-prem, so that we can actually run their algorithms inside the hospital data center and make sure that none of that data leaves their data center.
Gotcha. So maybe could you guys talk about some of like the clinical focuses? It looks like obviously oncology seems to be one of your clinical focus. I saw you guys have like an orthopedic application as well for like detecting fractures and things like that. So maybe some of the clinical areas you guys are focusing on it right now.
Yeah, so the way we think about it is radiology in isolation at a hospital. It's not one of the largest specialties, right? Where radiology is really important is that it's become the primary diagnostic driver for most of the largest specialties, right? Cardiovascular, orthopedics, oncology, women's health. And if you're a health system and you're looking at your finances, you realize that every dollar of radiology revenue generated results in something like $74 of downstream specialty care. And so radiology is useful in that it is the kind of door through which patients enter the system and receive care. And so when we think about how is AI going to ultimately unlock value, you can't just think of it in the narrow context of radiology productivity or efficiency or malpractice. You got to think about it in terms of how does AI actually make radiologists better partners to the specialists that they work with. And so along those lines, we think of radiology in oncology, orthopedics, cardiovascular, neurology, women's health. We think about them in terms of those suites, right? Because if I'm trying to add value to my orthopedics team, they don't like a random tool for hip measurement or fracture or bone lesions. They're like, well, I kind of want you to be able to help them with everything, right? Like I don't want to pick and choose which applications you're supporting. So that's why, think about how companies work though. Like companies will struggle to put, any one company is going to struggle to build all of the algorithms needed in an entire category. Another example is women's health. Like the company that builds 2D mammo is different than the 3D mammo, which is different than density, which is different than ovarian lesions, which is different than ultrasound. So just to have a comprehensive solution that's gonna really fully support like a women's health department, you need a bunch of different vendors all joining together on a single platform. So those are what we call our AI hubs, is when we can bring together companies that have complementary products, but which taken together create a really compelling offering for an MSK imaging lead or for a department of orthopedics that's working with radiology.
From what I understand, there's hundreds of AI companies, even in the radiology space. Correct me if I'm wrong on that, and I'm wondering, like, how do you guys choose like which ones you incorporate on your platforms, and how that selection process is done?
That's a good question. So there was an interesting data point that came out recently where they interviewed a bunch of systems that were using AI, and they basically asked how many of your AI initiatives actually end up getting into production. And the question here becomes, turns out a lot of these tools, even after being implemented, don't work the way they're indicated, right? And it's because AI by definition is biased. It is a technology that just is going to be specifically biased towards the population it's trained on. And when 93% of all AI algorithms are trained on patient data exclusively from California, New York, and Massachusetts, you realize that a lot of these tools are going to struggle to generalize. And that's exactly what you see, right? If you have a population that doesn't reflect the demographics or the disease distribution or the scanner machine types of the vendor that you're working with, performance can be unpredictable. And the right answer isn't for every vendor to somehow train on every population. And it's also not for every hospital to only work with vendors that have trained on their, like, the answer is not limit how much AI you use. It's just, hey, you just got to test this stuff locally in order to have any knowledge. So we look at a lot of publications. We look at at companies' FDA clearances. And most importantly, because we have a platform that can really easily, one-click deploy these tools, we also are able to try before you buy for the hospitals we work with, right? We were able to run a validation study and actually implement them in a way that tells hospitals exactly how these tools work on their local population.
Interesting. Yeah, there's a a research group here at the radiology department at Emory, and one of the things they're working on is because here at Emory, in Atlanta, we have kind of a unique patient population where almost half the population is patients of color, and so we have a kind of an interesting opportunity here to train AI algorithms on a unique patient set. So I think that's interesting you comment on that, because I imagine that's a challenge, is being able to, because as you guys know, different patient populations, different races have different predispositions, if you will, to certain disease states and other things. So I think getting them generalized, and so that's interesting that you guys take that into consideration as well when both figuring out which algorithms to use and then also consulting different healthcare providers on which ones to use. So what's been the reception from the healthcare systems that have adopted your guys' services? How are they staying? I imagine it's making a lot of the radiologists' lives easier. Like, what kind of feedback are you guys receiving?
Yeah, so I think doctors aren't really used to, radiologists aren't really used to this idea of just being able to turn on an AI solution. And so there's a lot that can be done with that. For example, when we ran one of our tools that does fracture dissection on one of our customer sites, we were able to show them that they had twice the rate of error at the end of their shift between the hours of 4 and 6 as they did during the day. And this is something that we showed. This algorithm is literally flagging twice the number of actual confirmed misses in those hours than it is at other times of day. And they're like, well, that doesn't surprise us at all. We're a little surprised that it's almost double. But yeah, we're tired at the end of the day. The coffee's wearing off, or we're getting sleepy. And so they were able to take that and start really considering, hey, how do we actually drive workflow changes or staffing changes to try to eliminate this? Because they're like, we know this isn't just fracture. We know that this is all diagnostics that we're engaged with here. And we were able to show them that they were roughly 1 in 200 of their upper extremity X-rays, elbow, wrist, hand, contained a missed fracture. And that's, again, almost like 50 to 75% higher than other scan types. And so again, these AI tools being able to be deployed and actually deployed in a way that has analytics and monitoring around it allows us to meaningfully change not just the patient diagnosis with these AI tools, make more diagnoses, prevent patient harm, but literally allows us to identify the weaknesses in our practice patterns that you've been able to kind of work on and change. So I think these tools are fantastic when they're run across populations, but they're also leading some interesting insights on how radiologists work and where our blind spots and where our weaknesses are. It's
really interesting that you not only help what you initially set out to do, which is help obviously with diagnostics and things, but also improving workflow of radiologists. Because I imagine because what I've seen in some places where you'll have radiologists where their shifts will overlap or things like that. But I imagine not every place does that, it seems like you guys have found out. And so kind of help prevent that, like you said, the coffee wearing off or getting tired at the end of the shift or realizing you got to go and you kind of want to rush through those last few studies. So, and that's interesting. You found those areas, and that's really important, to help us do our job better and more effectively. So Ken, I'm curious at a high level, with working with the hospital systems and the IT departments, how has that been with working with those, and do they have trouble adopting them, and is there any kind of hangups you've run into with that?
I think going back to or combining this with that reception topic, ultimately we have a lot of positive interactions with the IT teams that we work with, and a lot of that is driven by one of our earliest goals of making it easy for IT so that we can work together to eventually get to that other goal of being able to essentially try and validate a lot of different algorithms and have this one-click deploy workflow so that ultimately the physicians and the patients benefit. And because of that, in terms of what an implementation looks like or what IT needs to do, there really isn't that much that's out of the ordinary. In fact, there's really nothing out of the ordinary. If we were to, deploy on-prem, which is healthcare's bias right now, basically they need to rack and stack our servers, give us some IP addresses, and then start sending us data. And after that, we do everything internally from figuring out what data should go paired with which ML algorithm, and then also figuring out how to best deploy the results of that algorithm and put them back in front of the physician's eyes.
Awesome. Thanks for that overview. I appreciate it. So as far as I'm curious more on the radiology workflow, and this may even just be a general AI question from what you guys have seen, but do you guys focus on, and maybe you mentioned this earlier, with helping with the workflow and essentially, because as we get more and more studies, it's, helping prioritize. I imagine that's where AI could really help. If you have a bunch of negative studies, but then you have that one, case where it's, acute appendicitis or something where you've got to call the clinician right away, and you don't want to get to that case later, sooner rather than later. So I imagine AI could help with that, and then maybe even tipping you off to that, hey, there's more, maybe a critical finding more so in this case versus some of the others.
Yeah, so in terms of workflows, I think we sometimes overthink what the workflows are going to be for AI, and we kind of make it too complicated for ourselves. We like to break it into three major categories of how these AI tools can actually be deployed. Well, three major categories and one separate one. But in terms of diagnostics, in terms of improving quality and outcomes, three areas. One is you can have AI running before the scan gets read, and that's called triage, right? That's called changing the order of what's being read at what time. And companies like Viz, ADOC, et cetera, are best known for this. Rapid. Two is computer aided detection, right? Where you are actually changing and adding additional things to what the doctor's reviewing. You're kind of changing their search pattern, et cetera. And then three is after the read, which is think of it as like a safety net or population monitoring, where you're actually running it as a safety net to try to find diagnoses or follow-ups or certain things that weren't documented or identified. And like those are kind of the three ways that you can actually implement AI in the read, right? It's not too complicated. The nuance becomes, okay, well, is it popping up via a widget or via the natural viewer? Is it being deployed, into Epic Radiant or some other work? The nuance starts to become when you realize that each one of those steps can be implemented like dozens of different ways. Our general inclination is just, radiologist workflows are already super fragile and refined and efficient. And so anyone who's trying to change workflows is going to have a rough time scaling a business. And so for us, we look for solutions and algorithms that we can deploy that fit into existing workflows without requiring retraining or kind of shifting of patterns.
Gotcha. Now, as I'm sure you both are aware, medicine is an area that's slow to change and slow to adopt things and often meets things with skepticism. So I'm curious, when you guys are talking with different hospitals or physicians and they're maybe considering adopting your services, if you get any kind of skepticism from them and maybe like how you guys talk to them through that and make them essentially see the light, if you will, that there's a more efficient way to do things.
Yeah, honestly, I think we are past the point where radiology. So we kind of had this like curve where like, oh my God, like AI is so exciting, and then oh wait, is it going to take all of our jobs? And then like, oh, okay, like this stuff actually doesn't work all. So the Gartner hype curve, right? We kind of have done this little spike here, and now we kind of in the valley of disillusionment, and now we're kind of clawing our way back out. And what happens when you're clawing your way back out is people realize that this nascent technology that we all thought was super promising actually needs a lot more features around it to actually make it usable. This happens in every industry, right? And so we're at a point where like, okay, well, like just having an algorithm that can predict a lung nodule in isolation doesn't work all that well unless it fits into a broader system. You have workflows around it, you have monitoring, you have platforms, you have update mechanisms, like all of the features that are required around this kind of single little diagnostic engine is what's being built now. So I think hospital systems and radiologists have realized that, right? They're like, yeah, like the toy that I was playing around with a couple of years back that will measure the diameter of a lesion automatically for me, like that needs more before it's going to actually be able to meaningfully change my workflow. But you have a lot of companies out there now, so it's reasonable to expect as we start to build these platforms that there's going to be value unlocked. So hospitals are all looking for platforms now. They're excited about these point solutions. There are too many of them to work with. And so if they're not looking to us, they're looking to their existing vendors, right? The Siemens, GEs, Philips, et cetera, of the world to help them with this. So that's kind of what we're seeing. I don't think there's much pushback anymore about the need for a platform because, people are like, well, we need to use AI and we can't work with every company that's under the sun. So we need some sort of connectivity there, which has been great for us.
Yeah, that's awesome. No, that's a really great point. And I had an attending at my program on who's part of that AI research group I was talking about. He was on the podcast a couple of weeks ago. I actually worked with him this morning too, in when I was doing ER imaging, and he made an interesting comment that AI is akin to when people switched from real physical plain films to electronic films. He said there were radiologists that transitioned and radiologists who didn't, and he goes, and unfortunately the ones who didn't kind of got left behind. And so he was kind of saying that the way AI is gotten to is where it's it's going to get to a point where there's either radiologists that use it or that don't, and it's kind of like the wave of how things should be moving, and you may get left behind if you don't.
I mean, I think you can still be thought of as being a good radiologist today without using AI. I think we haven't gotten to a point where you have to be using the AI tools in order to be a good radiologist. But reimbursements have dropped 50% per exam in the past 10 years. I think they're dropping further. You have CT scans have gone from low double digits number of slices to high double digit number of slices. You have a tenfold increase in the total amount of data being generated, and then you have an increasing amount of volume of scans as the population gets older and increasing complexity, and then the same number of radiologists. So you have these ridiculous pressures on radiologists where you are actually reading a CT scan in the time that you used to be able to read an X-ray, and you're being compensated half as much for it. So I think the pressure on radiologists just to stay afloat, just make the same amount that you made last year, and deliver the same quality of read, that's just going to snap, and it's already starting to kind of fray at the edges. And so I think when you look at being a radiologist 10 years from now, as these trends continue to order of magnitude increase in the way that we don't want them to, I don't think you'll be able to be a good radiologist unless you have a lot of these AI tools supporting you and kind of catching you where you fall, because you'll be reading 5 times as many CT scans in half as much time for the same amount of money. You're not going to be able to do that without the help of technology. We're already operating we're already redlining the radiology as a profession right now.
Yeah, no, 100%. I'll echo what you're saying. Everything I hear from attendees and then people that we hear about from private practice, that it's really, believe it or not, there's a lot of burnout in especially in diagnostic radiology, because for the exact reasons you're mentioning. That there's you have to read twice as many scans, and even at the big academic places, like Emory or like Stanford or UCSF, which is also out where you guys are, and the volumes are just going up everywhere. And then so I guess kind of going off that, I'm wondering, obviously these big academic places have a lot of radiologists, they have residents, they have fellows, they have a lot of support. You also have these hospital systems where they're in the more rural or remote areas where there's not as many physicians, but still can be, a number of patients. I'm curious if you guys worked with any of those or have any thoughts on how AI could really, I think, probably help those systems as well.
Yeah, I mean, I think that, and this is a health equity problem that I think isn't appreciated enough, which is we treat reading an X-ray as a commodity. If it's done by an overworked generalist at 2 a.m. who's doing a night hawk covering a rural hospital, I mean, we think of that, he read the X-ray, the output is going to be the same as the academic reading it in their room with a hyper specialist training. And that's not the case. And so when we're not able to measure error and we're not able to measure quality, you end up basically regressing to the lowest quality possible scan you can do without literally the floor being malpractice costs being greater than the savings you have for being understaffed. And that's not the floor you want to have. So I think where AI becomes interesting is that AI doesn't care if it's being deployed into a rural hospital or an academic teaching center, right? It's going to do the exact same thing for the exact same patient study, and that is actually a great equalizer, because maybe it's only being used for, I don't know, lung nodules and pneumonia and fractures, some initial use cases. But if we were able to deliver the same quality of diagnostic care for lung nodules or fracture or pneumonia in a rural setting as you are in a tertiary center, like you are bridging a massive care divide that people don't even recognize exists today. So that's one of the things that for us, when we deploy at a site like Sutter Health, or we deploy us at like a health system, multi-state health system, like, we really try hard to not just be deploying at, the super wealthy enclaves of those groups, but actually being deployed enterprise-wide.
No, that's great. I mean, I think as far as not only do you want to increase effectiveness everywhere, but also, like you said, like kind of these inequities that exist, across, you can have the same condition and go to, like Stanford Hospital or Emory Hospital, but you may not get necessarily the same, because they just don't have the same resources. But I think doing something like this, like you said, would definitely really help for sure. I guess kind of going off that, with any new technology, there's always new unforeseen problems that arise. And I think probably AI is no different. I guess I'm curious, what are some of those you guys have seen, and how have you guys try to help mitigate that, or help your clients mitigate those?
Yeah. One of them is that there is a very low correlation between stated performance of an algorithm and actual performance of an algorithm. And by I mean very low, I mean like there's no way to tell. your FDA clearance could be just flawless, right? It could look like a journal club case study, and then you could just completely underperform across populations. And it's because the vast majority of these tools are being validated on the same population they're being trained on. So all you're really doing is saying how good can you train the algorithm to kind of overfit a model. And so that's one of the big challenges that I think we're still coming to terms with as companies come out, right? Like there's no reward for being a good and kind of developer right now. And that's got to change. And that's one of the things we're trying to drive is awareness and transparency into these AI performance. And so, we're trying to integrate and work with systems that, they want to be reporting into registries like, ACR, DSIs, right, SFAI, or patient safety organizations that collect this data and want to say, hey, like, here's actually how these tools perform. Here are their blind spots. Here is where they're useful. Here's where they, may be kind of noisy, and actually driving, the sharing of these insights between organizations for vendors. And that's something that, like, it is shocking that hasn't happened yet. That if I'm deploying, a PE solution at my institution, there's no way for me to get visibility or have any idea of how that PE solution has worked at my neighboring facilities. Even if, everyone else is using it, 10 other facilities using it, I have no way to know what their outputs are, right? All I have are anecdotally, like, oh, I talked to this radiologist and they said that it was kind of nice. Or I talked to this other radiologist at another site and they said it was kind of noisy. Like, that's kind of all we have to make sense of the noise. And AI is a quantitative field, right? We should be able to know exactly how these tools perform, what their outputs are, what their weak spots are. We should be able to share that stuff between organizations. And I think when we can do that, we're going to end up with a much more rapid adoption of these tools, because you can finally trust to kind of have a semblance of what it's going to look like when you deploy it. But there's no trust left anymore in the space, and we've got to somehow fix that.
No, that makes sense. No, and I commend you guys for working hard to help build that trust back up. I'm curious, Ken, on your end, on the tech end of things, where has your role or your experience fit on this? Like, what kind of feedback have you received from maybe the tech side of things on issues that come up, or how to mitigate those?
It really is central around the point that Pelu is talking about the lack of trust and the disassociation between what vendors and partners say that their performance is on paper versus what we see in real life. And we get that, same ask for clarification from the people we work with on both sides of this table, both from the hospital side and also from the partners, because, their performance is something that they have pride in, because it is something that they're optimizing for. And being able to see that, that there is a missing gap or there's additional room to grow in particular patient populations is something that they want and we want for the patients ultimately. And, just goes back to the same points of just making it easy to validate these algorithms so that we can start measuring, so that we can start improving.
Awesome. Yeah, I imagine that's people overstating. I mean, that's an issue that's across many things and almost as old as time. But but I think I imagine that's validating what they say it actually can do. I'm curious, do you guys ever validate it and then turn it out on the actual population, and then everything you maybe did in your kind of pre-vetting process made things look good, and then it actually, when you turned it live, there were kind of unforeseen maybe issues that arose as a result of that, or that were unforeseen, if you will?
Nothing that reaches the doctors, because that's kind of the point of having a platform partner, right? Like, I think I do hear a lot of nightmare stories around IT organizations that basically end up in this like multi-month long slog of like trying to figure out how cloud APIs work with these vendors, sending the wrong data, just having, basically like, anything that can go wrong will go wrong with a lot of IT organizations. And so we found that the less you require of them to be able to implement, the kind of better off they're going to end up being. So for us, we have full control over the platform from the hardware on up through the containers that we host the algorithms within. And that gives us a lot of control, right? If anything, I think that the challenge for us becomes making sure that we are like keeping up with the requests that are coming from providers now, because now that providers have our platform installed, they're like, okay, cool. Is there a thyroid tool on this platform? Is there a pancreatic lesion tool? Is there a bone lesion tool? Right. I think once they realize, we can actually try this stuff out and see what works, radiologists tend to get excited and they tend to like want to try more things out, and it's just keeping up with that. And then there are a lot of solutions that are on the market that are super niche, and like they're never going to be able to be monetized individually. And there's a lot of research that's out there from academics that will never be a company, right? So you may develop an algorithm that is like the world's best, I don't know, like a lymph node measurement tool for metastatic disease staging, and like it's like you're never going to build a company around that, right? However, it's a really powerful tool that if offered in an oncology hub or in a suite of solutions, could save doctors a lot of time. So I think the next step for us is going to be really trying to find ways to get a lot of these smaller point solutions that will never make it to become a company to actually have a path to market. And I think that would be pretty cool.
Yeah, definitely. So if a practice or a hospital, I'm just curious as we're talking about this, if they don't use like your guys' company, I imagine do they have to vet all this stuff themselves and if essentially figure this out on their own? And then I could imagine that is a huge barrier to adopting AI into their practice.
Yeah, I think we spoke with a few of our health systems that we've known for decades, and we talked to them about what the actual cost of implementation was for any given solution, not even AI, but just like a new vendor, a new tool. And it measures in the hundreds of thousands of dollars and in the kind of 12 to 18 months timeframe at best. And so, FDA clears 100 or so AI tools per year, and probably several hundred just general clinical tools per year. Hospitals are currently able to implement one every year to year and a half. And so, it's not that they can't do it, right? Clearly there have been commercial successes in AI. There are folks who are deploying lung nodule tools or, PE tools or triage tools. Like, there are successes, but the successes are occurring, in, these 1 to 2 year increments. And so we're 2 orders of magnitude off, right? We're not 10x slower, we're 100 times slower than where we need to be as a kind of profession in terms of adopting technology. And guess what? Like, AI is only going to continue becoming easier to build, more powerful, and therefore covering more use cases. So we're going to go from being 100 times too slow to being 1,000 times too slow in the next couple of years. And at some point, right, like that's got to break because there's just too much value. There are too many patient lives at stake. to continue just like, implementing, one new solution year. This year we'll do fracture. Next year we'll do PE. The year after we'll do, breast tomo. And by the time that happens, my fracture tool will be out of date. Like there's no universe where that actually ends up being the way that healthcare modernizes.
I see. That's interesting. I'm curious from, there's a lot of offerings out there of technology where, the doctors really like it. They think it's really useful. It helps give better patient care. But as you know, unfortunately, sometimes it can be hard to get like the administration to buy into that. And like, you've got to demonstrate, I imagine, some kind of value add or cost savings or things like that. How do you guys like mitigate that aspect of trying to work with some of these hospital systems?
I think this is actually where radiologists who are forward looking actually most differentiate themselves. Because if I am a radiologist who is thinking about what my profession is going to look like in the future, I am thinking of my role with regards to the broader care team, to the specialists I serve, and to the value I add them, and I'm working on those relationships. And so I've got a good relationship with the chair of ortho and the chair of oncology, where we understand the role I play in the patient's diagnostic journey. And when I want to deploy tools that improve the diagnostic journey, they've got my back, right? I've got the chair of ortho saying, hey, listen, our clinics are failed because radiology makes these diagnoses, right? They're doing a great job, but there are areas that, we could be driving more care, preventing patient harm. And I'm willing to say, if I get more patient visits, if I do more surgeries, if my patient outcomes are better because of radiology being a good partner to me, I'll support them in that. Versus what kind of happens now, which is chair of radiology arguing for budget for their toys against the chair of ortho who's arguing for budget for their toys against cardiovascular who's arguing for budget. Like right now, there's kind of this feeling that radiologists have to fight other departments for budget. And I just have never seen that be successful because at the end of the day, radiology's value, again, $70 to $1, radiology's value is the care that their diagnoses generate. So I think the groups that we work with that have strong relationships with the specialists that they partner with and serve, they are able to get these initiatives through. They're able to meaningfully transform practice, get access to budget they otherwise wouldn't. The ones who kind of just try to go it alone and try to focus on tools that drive incremental efficiency or auto reporting or left-right mismatch. Like there's some tools that radiology can in isolation say, yeah, I'll be able to read 3% more studies. Or there are tools like that, but that's not where AI is going to transform radiology. And if you keep trying to do that, you're going to end up replacing yourself. So that's how we think about it.
Excellent. I'm curious also with applying these in the more rural areas and things like that. Where maybe they have limited resources. Have you run into any situations like that where they don't have necessarily the tech infrastructure to do this, or is that, and is there ways you guys help them mitigate that, or has that not really been an issue maybe?
Yeah, I mean, I think one of the, I guess I want to say fortunate, but somewhat unfortunate things is that, standalone rural clinics, unless they're federally funded, they're just getting rolled up, right? You don't really have this notion of a standalone hospital anymore. You've got to be part of a larger system. And so because of that roll up, one of the first things they do is, the last thing a rural clinic wants to do is manage its own IT. So we've actually, we've seen regional roll-ups be kind of the name of the game. And for us, as a platform, we're most valuable to large systems, large groups, large practices that are going to, that actually have volumes that are going to be meaningful and have multiple stakeholders demanding different things. And so for us, we generally play on the larger side of the market. And so we don't have as much opportunity to really work with these smaller practices and groups.
Gotcha. Interesting. So I wanted to ask you guys, kind of looking forward a little bit, what are your ambitions kind of in the next year, 2 years, and both Pelu from your standpoint on kind of the overall vision and the clinical side, and then Ken from your side on the technical aspects as well, and what you guys are excited about and what you guys are trying to accomplish in the near future here.
Yeah, so I think we grew the number of applications that vendors that we work with and the number of use cases on our platform. We grew threefold last year. We're doubling it this year, and so we're at a point where I think we are onboarding and adding vendors and getting them installed at hospitals at a faster rate than anybody else's, right? Like we had an installation, Carl Clinic over in Illinois, where we actually turned on I think 5 different solutions, and we're like launching new ones every few quarters, right? And so I think this idea that a hospital system working with us can go from 0 AI capabilities to working with a dozen different vendors in the matter of a few months, going to catch up to some of these folks who have been trying to bust down the doors of AI for 5-7 years now, and that overnight you could actually meet and exceed the amount of usage and kind of the tools that you have integrated. I think that's something that we've finally started to prove. So that'll be an area where we, our goal is, everything we're investing in is basically, we're clearly able to get hospital systems from 0 to 5 to 7 algorithms being used in, a month or 2. How do we get that from 0 to 10, 0 to 20 algorithms that are being deployed scalably, sustainably, with ROI, et cetera, as an initial installation? And so for us, it's how many patient lives are we covering, which is how many hospital systems are we working with, how many radiologists are we deploying into. Then it's going to be how much AI are we running for them, how many tools per site are we actually launching. And those two metrics end up giving us our North Star metric, which is number of patient predictions and total impact that our platform is having. And that's our North Star. That's going to be the case. It was the case when we first launched. It's going to be the case 10 years from now. Is the more AI that we can enable hospitals to deploy in the patients, ultimately, right, like unlocking that next order of magnitude every year or 2 is going to be how I think we drive change in healthcare.
Awesome. No, thanks for that overview. Ken, how about on your end? What are your kind of big missions or aims you're working through in the near future here?
Oh man, I mean, at the end of the day, it's enabling all of that is the easy answer. But the few things that we are working on and have our eye on is starting off with optimizing our validation workflow, making sure that as we have additional applications that people want to use, we want to be able to make the rate of turnaround time for validations a lot lower than they are today. Where it takes 1 week, we want to bring it down to 1 day, something along those lines, so that we can help these healthcare systems and facilitate them to actually try out additional algorithms and see what really works best for them. Because at the end of the day, we got to match the two. There's also things like reducing the time for installations. Again, bringing down something from like 8 hours to 2 hours. There's always going to be a hard limit if you're working with on-prem solutions because someone needs to unpack the box. But as we start to talk about and find places that are more open to cloud solutions and cloud-based solutions, then facilitating that and making sure that the cloud installations are actually more aligned with something one click, something that IT can do on their own, and something that becomes very low burden is definitely one of our goals. And that actually dovetails with scaling and keeping ahead, really, of the scale of apps that we need to support in terms of volume, in terms of data, in terms of number of applications. And that's, again, with multi-cloud for systems that already have servers that are on-premise within their data center, but they want overflow capacity, for instance, if they realize that they want to try out more than they can really handle with the servers they have. And also with horizontal scaling with these technologies like Kubernetes and just making sure that that's still efficient. And then the one thing that we really want to bring onto the table is making observability available to our ML partners and to IT teams. And so what that looks like is being able to provide them a lot more insight and data into how their applications are performing more real time across the sites that they're deployed at so that they can make improvements faster. And then also for our health IT teams to be able to understand how the ML applications that are deployed at their site are improving patient care at the end of the day.
Awesome. Thank you both for giving me that overview, and congrats on your rapid growth already. That's awesome. And then, I wish you all the best with moving forward on that. I guess I'm curious, kind of closing things out here. Obviously you guys are primarily focused on radiology and imaging. Have you any thoughts on expanding into other areas where AI has been, talked about being applied or being currently applied, like dermatology, pathology, I've even heard talk of, using it to like scan charts in primary care clinics, because you can go, much more efficiently go through charts and flag things that are important to look at. I'm curious if you guys have any plans or thoughts on that.
I mean, if you read through the FDA clearances that are being made, like 2/3 of them are imaging, right? I think imaging is the most mature, it's the most standardized, and that's one of the reasons why radiology has always been at the forefront of technology, is because unlike dermatology or pathology or the EHR as a whole, we got DICOM, right? We got standards, and as a result, technology is able to scale in our profession much faster than it is in other places. Our platform is agnostic. And so, in a world where every dermatology image was stored in a central archive and accessible, which doesn't exist, or in a world where pathology was digitized, which doesn't exist, I think our platform will be just as capable of running those sorts of algorithms as it would be imaging. I just don't think a lot of other specialties are at a point of standardization and digitization yet, which is crazy to me, but we're in healthcare. We all are constantly surprised about these things.
No, that's an interesting point you make, especially about dermatology. One of my previous podcast guests is Dan Lambert, he was CEO and founder of Board Vitals, which was like a big med ed company, and then now he's CEO of this company called Pathology Watch, which is working to exactly do what you're talking about, which is digitize dermatology and dermatopathology images. And then I think their plans are eventually to utilize AI, but I think kind of the first phase right now is to get them digitized. So I think it's interesting you say that how radiology is ahead of the curve, and that makes it obviously much more impactful and much easier to scale, which is pretty cool. I guess we ask every guest this, you guys are very busy, you're running a startup. How do you guys balance your lives outside of work? Where do you guys find that balance?
I don't think I understand the question.
Yeah, what is balance, right?
I think my hobbies kind of force me to balance because they disconnect me from the world. Like I do a lot of photography while I'm climbing and canyoneering in alpine and mountainous environments. And in those situations, there is not always a cell tower to get Slack messages or emails. So at least for the weekends, I am disconnected.
Awesome. Well, thanks again, guys. Appreciate you, taking time out of your busy schedule to talk with us and tell us more about what Ferrum Health is doing. I guess kind of lastly, where can they find you guys? How can people get in touch, reach out, talk with you more about what you guys are offering and get possibly adopt it within their system?
Head to our website, ferrumhealth.com. Or ferrum.ai, whichever you want, depending on if you're a techie or if you're a hospital administrator. Those are the same place. And then, shoot us an email. It's first name at ferrumhealth.com if anybody wants to learn more.
Awesome. Well, Pelu, Ken, appreciate you guys taking time. Really insightful stuff and really innovative. I really appreciate it.
Likewise, this was the last.
Yeah, thanks for having us.
Thank you for listening to this episode of the DaVinci Hour podcast, presented by DaVinci Academy. Please be sure to subscribe to our YouTube channel and follow the podcast on your podcast platform of choice to catch the latest episodes. Please leave a comment or a review and share it with a friend. Lastly, you can find all of our podcasts, video courses, and books on our website, dviacademy.com. Thank you for listening.